What's up guys, Muhammad Farhan Labib here, a second year MBBS student at GMC Guwahati, and in this particular video I have tried to simplify the concepts of electrical activities of heart. So let's dive into the topic. Alright guys, so in this video we will talk about the electrical properties of heart. The electrical properties of heart. Now whenever I say electrical properties of heart, the two different types of electrical activities which are seen in heart is number one, the Plateau potential, and number two, the pacemaker potential. Now what is this potential guys? Whenever I use the term potential, it means that there is a fluctuation of the voltage with respect to time, right? And where is this plateau potential found? The site of occurrence of this plateau potential is the cell membranes of the contractile tissues of the heart. Cell membrane of what? All contractile tissues of heart. In addition to that, it is also seen in all nodal tissues. All nodal tissues except, exception is very important guys, except what? Except the SA node and the AV node, right? And this pacemaker potential will obviously be found in the SA node and the AV node. Now before proceeding, let me tell that this SA node is what? This SA node, as you all may know, that this SA node is the pacemaker of the heart. But do you know why is this the pacemaker of the heart? Why is SA node the pacemaker of heart? SA node is the pacemaker of the heart because it generates maximum number of impulses per minute as compared to other nodal tissues. Maximum number of impulses per minute as compared to what? As compared to other nodal tissues. Now guys, let me tell a very important fact about this AV node is it undergoes an AV nodal delay of 92 millisecond, which if we convert into second is 0.092 seconds of what? AV nodal delay. Now what is the logic behind this AV nodal delay guys? The logic behind this AV nodal delay is that AV node has very few gap junctions, right? It has very few gap junctions. In addition to that, it has a small diameter of fiber. AV node has got what? Small diameter fibers. Due to the presence of very small diameter fibers and very few gap junctions, this AV nodal delay is seen, right? Alright, now what is this advantage of this AV nodal delay guys? Advantage of this AV nodal delay is that this AV nodal delay enables what? Enables the atria to undergo contraction ahead of the ventricle. Now imagine guys, impulses are taking some time, are taking a delay of 92 millisecond in the AV node. This will enable what? This will enable the atria to undergo contraction before the ventricle. Very simple, right? So now let us dive into the important part, that is what? That is the plateau potential. I already mentioned about the sites guys. The sites for undergoing this plateau potential was what? The sites were all the contractile tissues and all the nodal tissues except the AV node and SA node. Now what do I mean when I say this? All contractile tissues and all the nodal tissues except the SA node and AV node, which means it will include the internodal tissues, right? The bundle of His, the left and right bundle, isn't it? And it will also include the Purkinje fibers. Purkinje fibers. So these are the tissues where we can see what? Where we can see the plateau potential. Now what is the resting membrane potential of these cells undergoing the plateau potential? The resting membrane potential for them is minus 90 millivolt. This is mostly for this contractile tissue. The resting membrane potential for this contractile tissue is how much? Minus 90 millivolt. Alright. Now whenever this contractile tissues receives a threshold of plus 15 millivolt, right, then this will change the potential to minus 75 millivolt, and this is when the actual depolarization will start. Simple. Now let us represent it in the form of a graph. So draw the graph. right? So this is how the graph look like. It has got a plateau part and then a descent. Okay guys, so this is what, this is minus 90 millivolt. This signifies minus 75 millivolt, where it has attained the threshold, it had received the threshold. And after that, after this, the ascent of up to plus 20 millivolt is seen, which is the spike potential, and then we see a declinement, we see a plateau part, and again we see declinement, right? So what are these different phases, guys? This potential, this plateau potential can be divided into different phases, which are phase 0, phase 1, phase 2, phase 3, and phase 4. This phase 0 is also known as what? Depolarization. Obvious. Phase 1 is also known as what? Phase 1 is also known as early repolarization. Phase 2 is known as the plateau part. Phase 3 known as the late repolarization, and phase 4 known as the hyperpolarization. Now let us see the reasons, guys. Why is this depolarization formed? This depolarization is caused due to the influx. Influx of what? Influx of sodium ion. Whenever it receives the threshold, guys, such that the minus 90 millivolt changes to minus 75 millivolt after receiving a threshold of plus 15 millivolt, guys, that is when the sodium channels ion open. Now since the concentration of sodium is more in the extracellular fluid as compared to that of intracellular fluid, hence the influx of sodium is seen, creating what? Creating ascent of the graph, right? Now after it has achieved a potential of plus 20 millivolt, that is when the early repolarization will start. Now what is the reason for this early repolarization, guys? The reason for this early repolarization is that the sodium channels close and potassium channels open. Now as soon as the potassium channels open, we know that the concentration of this potassium inside the cell is more as compared to that of extracellular fluid. Hence this efflux of potassium ion is seen, right? Efflux of potassium ion is seen. That is what leads to the descent in the graph. Next to that, we have the most important part, that is the plateau potential or the plateau part. This plateau part is created by two factors. One is because the potassium was already undergoing efflux, right? And another important thing is because of the calcium influx. Now imagine, guys, positive ion, that is the calcium ion, is undergoing influx, and here the potassium ion, which is a positive ion, is again undergoing efflux, nullifying effect, producing the plateau part, right? Now let us talk about the next part, that is what? That is the late repolarization, guys. This late repolarization is again attributed to what? Is again attributed to potassium efflux. All right, now the phase 4, which is nothing but this hyperpolarization, is due to what? Due to the slow closure of this potassium ion. Slow closure of potassium channel, which leads to the excessive loss of potassium ion, creating this phase 4, right? Now at this point of time, we should know an important term, that is the absolute refractory period. What is absolute refractory period? Absolute refractory period is the point where it underwent what? Threshold stimulus, the point where the actual depolarization began, till the 1/3 of the repolarization. That is what is known as absolute refractory period. Now in this absolute refractory period, guys, absolute refractory period of what? The cardiac myocytes or the contractile cells of the cardiac cells is exceptionally long. Exceptionally long absolute refractory period. Due to this exceptionally long absolute refractory period, guys, what happens is cardiac contractile tissues do not undergo tetany. Do not undergo what? Tetany. What is tetany? Tetany is a state of sustained contraction. Because we know that if another impulse comes in this absolute refractory period, it cannot generate a new impulse. That is the reason behind not creation of tetany in the cardiac myocytes. So this was all about the plateau potential, guys. Now let us move on to what? Let us move on to the pacemaker potential. What did I say? The pacemaker potential is seen in the most important SA node and the AV node, right? Now, special characteristic feature of this pacemaker potential is that, you know, whenever its resting membrane potential, that is minus 60 millivolt, goes to minus 40 millivolt, this does not require a threshold. No threshold required. Then how does it go from minus 60 millivolt to minus 40 millivolt? This movement of this, you know, resting membrane potential, from this change actually of resting membrane potential from minus 60 millivolt to minus 40 millivolt is spontaneous, right? And what are the factors which creates this spontaneous change of this resting membrane potential? Factors are: number 1, decreased potassium efflux; number 2, opening of F channels. F channels are also known as funny channels, right? These funny channels are also known as HCN. Hyperpolarization activated cyclic nucleotide channel, HCN channel, guys. Now let us talk a little bit more detail about these funny channels or these HCN channels. Let us consider this is the HCN channel, this is the extracellular fluid, this is the intracellular fluid. Now what happens is in this HCN channel or funny channel is that influx of sodium ion is seen and efflux of potassium ion is seen. But this influx of sodium ion overrides the efflux of potassium ion, right? So there is what? A net positive charge is acquired, isn't it? More sodium ion is coming as compared to that of potassium efflux, so a net positive charge is acquired. Even in the case number 1, factor number 1, what we saw is decreased potassium efflux. So again, it will contribute to what? An increase in the positive charge inside the cell, isn't it? Now the third factor is creation of calcium spark. Calcium spark, guys. Why is this calcium spark produced? This calcium spark is due to the opening of transient calcium channels, which causes a massive influx of calcium ion. So this will lead to a calcium spark and again a net gain of positive charge. So what we saw is in these 3 factors there is always a net gain of positive charge, isn't it? So this net gain of positive charge is what will enable the spontaneous movement of the resting membrane potential from minus 60 millivolt to minus 40 millivolt in SA node and AV node. And this is nothing but what? Known as prepotential, or it will also be under the phase 4. So what is prepotential? Prepotential is the spontaneous change of the membrane from minus 60 millivolt to minus 40 millivolt, initially caused due to the decreased potassium efflux and most importantly contributed by this calcium spark, most contribution. In addition to this too, a contribution from this funny channel is also seen, isn't it, guys? Now let us represent this pacemaker potential in the form of a graph. So this is exactly how a pacemaker potential looks like. This is how much? This is minus 60 millivolt. This will be minus 40 millivolt, which is spontaneous, or the phase 4, right? And then the actual depolarization will start. But until when? Until a spike potential of plus 10 millivolt, right? And after that, repolarization phase will start, right? And then again we see the phase 4. So this is what? This ascent is nothing but the phase 0, and this descent is nothing but the phase, how much? Phase 3, right? And this is again the phase 4. All right, so in this pacemaker potential, phase 1 and phase 2 are absent. Clear? Now let us see the reason, right? let us know the logic behind this inclination of the graph and the declination of the graph. This phase 0 here is produced due to the calcium influx, guys. Calcium channels open, which is contrary to that of the plateau potential thing, is that here a calcium influx is seen, right? And once it reaches a potential of plus 10 millivolt, then a declinement of this graph is seen due to the closure of this calcium channel and opening up of potassium channel. Opening of potassium channel, which will lead to what? Potassium efflux. Now, if potassium efflux will take place, then there will be loss of positive charge leading to the declinement of the graph, right? And then again, the phase 4 is seen, whose reason or logics have already been discovered, already been discussed in the form of 3 points, isn't it? So this is what your pacemaker potential is, right? Now let us talk about the effects of sympathetic and parasympathetic discharge on this pacemaker potential. Alright guys, so number 1, sympathetic discharge. So whenever the sympathetic discharge, that is the norepinephrine, will increase, in that particular case the the beta receptor which is present in the SA node will get stimulated. Now this will lead to the production of lot of the second messenger of cyclic AMP, which will increase the impulse genesis from SA node, increasing the heart rate. Clear? Sympathetic discharge will increase the heart rate by increasing the impulse genesis from SA node by stimulating the beta receptor which is present in the SA node. Now talking about the parasympathetic discharge, guys, effect of parasympathetic discharge. You need to know that in SA node, a receptor, parasympathetic receptor or muscarinic receptor, that is the M2, is present, right? So whenever acetylcholine stimulates this M2 receptor, then what will happen is this empty receptor is what is this empty receptor is actually a G protein linked receptor, GPCR, right? And whenever this acetylcholine stimulates this M2 receptor, what will happen is potassium efflux is seen, right? This will hyperpolarize the nodal tissues of the SA node, isn't it? And due to this hyperpolarization of SA node, what will be seen is a reduction of heart rate is seen. Due to what? Due to reduced impulse genesis. Clear? So the parasympathetic discharge is doing what? The parasympathetic discharge is basically reducing the heart rate by reducing the impulse genesis due to the stimulation of M2 receptor, which is causing what? Which is causing potassium efflux, hyperpolarizing the SA node. So this was all about the electrical properties of all for today, guys. Subsequent topics of CVS Physiology will be dealt in upcoming videos. Even if the video added a tiny amount of value to your life, like our video, subscribe to our channel and share it with ones who need this kind of contents. So thank you.